Good morning, good afternoon, and good evening. Welcome all of you to the live program number 142 at Orthopaedic Principles. Today, our guest of honor is distinguished faculty, Professor Dane Wukich from the UT Southwestern, Dallas, Texas. Professor Wukich is professor and chair of the Department of Orthopedic Surgery at UT Southwestern, where he holds the Charles Gregory Distinguished Chair in Orthopedic Surgery. He's also the medical director at the UT Southwestern. Prof. Wukich spoke on ankle fractures in diabetics, calcaneal fractures, and diabetic foot earlier with us. And today, Prof. Wukich will enlighten us on the diagnosis and treatment of Charcot NeuroArthropathy. Today, it's my great honor to have Prof. Wukich back with us. Over to you, Prof.
Thank you very much. Good morning, and thank you for having me present this interesting topic. So the goals of this presentation, because Charcot is a very, very complicated area, it's hard to cover everything in a relatively short presentation. So I hope that this will be a presentation that will allow us to define what is Charcot, to talk a little bit about the epidemiology and prevalence, the pathophysiology, the impact on health-related quality of life. And finally, just get into a brief overview of the treatment. Treating Charcot is a very complicated, and we could spend a whole morning discussing the non-surgical and surgical options. And finally, like I mentioned, the definitive surgical treatment is beyond the scope of this particular talk today. So what is Charcot NeuroArthropathy? We know that there is some form of injury, and it creates either a fracture, a dislocation, or a fracture dislocation. And this injury may or may not be perceived by the patient. It could be a contusion, it could be a sprain or strain, a stress fracture from overdoing it, it could be a true fracture from a fall, or it can even occur after revascularization. In about half the patients, we don't even perceive any particular trauma, but it may be due to excess walking. I've seen it in patients who are mowing their grass, who have attended amusement parks, or go on a long walk or a hike. But the key thing that I would hope that all of you would take away from today's talk is to have a high index of suspicion in high-risk patients. How common is Charcot? The answer is we really don't know. The definition of a rare disease in the United States is a condition affecting less than 200,000 people. So quite honestly, as I'll show you, this would qualify as a rare disease. Our Congress in 1983 created what was called the Orphan Drug Act because the drug companies didn't want to spend money on conditions that were relatively rare. And as you can imagine, they're going to put money into very common cancers or heart disease, but not something that doesn't occur very frequently. And so I would say to you that we probably underestimate the prevalence of Charcot for a number of reasons. One is some patients may not present to us. Number two, patients are misdiagnosed often as cellulitis, deep vein thrombosis, or even gout. And finally, there's a delay in diagnosis. So getting back to how common is Charcot, one of the best studies that I was able to come up with is from it's from Ireland. And they looked at the prevalence, demographics, and outcomes in a regional referral center. This is a good study because there's National Health Service there and they can track all of their patients. What they found that in their center, the prevalence was 0.3% of all patients with diabetes. That's 3 patients for every 1,000. It was more common in males, nearly 2/3 of patients, more common in patients with type 2 diabetes. And it's interesting, in their particular center, nearly 40% of patients ultimately developed a foot ulcer. And we'll find out why that's very, very important. 20% of them had some form of amputation, but only 5% of the patients in this particular center had undergone a surgical procedure. Now, last week I talked about diabetic foot ulcers and I used this same slide. If you look at the global perspective in patients with diabetes in millions, you can see that China, India, United States, Pakistan, Brazil, Mexico, Indonesia, Germany, Egypt, and Bangladesh are the most common, and they have a large portion of patients with diabetes. And again, I showed this slide that if you looked at diabetic foot ulcers occur in about 2% of patients per year. So I took that same data and converted that to Charcot with a prevalence of 0.3%. And you can see that in China, nearly 350,000 cases of Charcot would be estimated. In India, over 200,000. In the United States, almost 100,000. And as you can see, going forward. So while yes, in the United States, it would qualify as a rare disease, it would not be a rare disease in India or in China. So if you look at the International Diabetes Federation, and this is data from 2017, they estimated that over 400 million people who were adults were living with diabetes. And the proportion of type 2 diabetes we know is increasing in most countries, especially developing countries. 80% of diabetes, again, you think about that, are living in low and middle income countries, those developing countries. So if I did that same statistic, that would mean that worldwide, there's over 1 million people with Charcot out there. So this is actually a problem, I think, from an epidemiologic standpoint, especially when we think at it as a global problem. It may not be a problem in your particular center, but as we aggregate patients, we can see that it is in fact a significant problem. Now, I then took this in the United States and compared common fractures that we see. And in the center, in the orange box with the blue around it, you can see is Charcot. But Charcot, the prevalence was more common than talus fractures and Lisfranc fractures, slightly less common than calcaneal fractures, and significantly less common than metatarsals. So while it's a rare disease, it's not uncommon for those of us that treat patients with Charcot. And again, I think that we underestimate how many cases there are because we don't see some of the patients. Why is it important to recognize Charcot? Because the pathway begins with a high-risk patient who has neuropathy. That patient gets an injury and develops a Charcot foot. That Charcot foot develops a deformity. It then develops a foot ulcer, an infection, and ultimately an amputation. We want to prevent amputations. How can we do so? By shifting all this to the left when they develop that Charcot deformity to try and really make that foot plantigrade so they don't develop a foot ulcer. If you look at this study from Diabetes Care published from the veterans data, they found that once a patient with a Charcot foot developed a foot ulcer, their risk of amputation went up by a factor of 12 or 1,100% higher. And so to me, if we can prevent a foot ulcer from occurring in a patient with diabetes and Charcot, we can prevent an enormous number of the amputations that occur. And so how do we go about doing that is what I hope to talk about. What is the pathophysiology? As I've mentioned before, we have some form of injury. That injury results in an acute inflammatory response. Blood circulation increases, bringing in all the inflammatory cells. You get the hyperperfusion, the hyperemia. You get osteoclasts migrating to the site of injury, and you lose bone integrity. And ultimately, what starts as a bone contusion can end up in a frank fracture or ligamentous rupture or a fracture dislocation. And so this is a case with a very, very subtle widening of the plantar aspect of the first tarsometatarsal joint. Was actually recognized early and treated in a total contact cast. But as you can see, that even despite 12 weeks of total contact casting, this relatively well-aligned foot fell apart and ended up with a non-plantigrade foot. So the balance between osteoblasts and osteoclasts is tightly regulated in normal healthy bone. All of us have this going on. But in a person with a Charcot foot, the balance between osteoprotegerin and rank L gets disrupted. Rank L stimulates osteoclastogenesis, whereas osteoprotegerin, or OPG, acts as a decoy receptor and blocks rank L from causing the osteoclastogenesis. And so that's really what happens in this acute inflammatory response that we somehow need to disrupt. We as orthopedic surgeons know about the orthopedic implications of rank and rank L. We have seen it in osteolytic bone metastasis. We see it in osteolysis following total joint arthroplasty. We see it in Paget's disease, and finally, in patients with osteoporosis. A great study done in London on increased osteoclastic activity in Charcot was done where they took peripheral monocytes from the circulating blood in acute Charcot patients, a group of diabetic control patients, and healthy control patients. And they took these monocytes and they cultured them with macrophage stimulating factor. As you know, macrophages and osteoclasts derived from the same cell line. They incubated them with rank L. And what they found is that in vivo, they found that Charcot peripheral monocytes had much greater osteoclastic resorption than diabetes patients in general and healthy control. So this was a pivotal study that actually showed that this was circulating in the peripheral serum and wasn't necessarily just a local phenomena from the Charcot. And so remember that when you look at these, not only did they increase the osteoclastic resorption, but the osteoclasts that were cultured were much more aggressive than the other osteoclasts. So again, getting back to the pathophysiology, an acute injury releases these inflammatory cytokines that activates rank L, and rank L in a person like this who has an injury or overuse. As you can see, this is a high-risk patient. How do we know that? They've had a previous 5th metatarsal ray amputation. They've had a 4th toe amputation. So clearly, this patient has underlying neuropathy because they had an infection. They're at high risk. And what happens is you get an imbalance in the production of osteoclasts and causing resorption, and you end up with this foot. And that X-ray on the left is the same person as on the right. I just had the opportunity to see it when they were acutely inflamed, and you can see that what happened to this particular foot because of the osteoclasts coming in and resorbing. So the clinical suspicion for Charcot. If X-rays are obtained, and in my opinion, everybody should have weight-bearing X-rays, most of these patients don't have significant pain, so you should be able to do it. You'll see subtle changes on weight-bearing films that you might not see on a non-weight-bearing film. If the X-ray is positive, you treat for Charcot. If the X-ray is negative, though, you have to prove that you don't have a Charcot in a high-risk patient. And that high-risk patient is anybody with peripheral neuropathy. An MRI is preferred, but if you don't have an MRI, you can use a CT scan or even a bone scan. Or you treat the patient as if they have a Charcot until their inflammation resolves. And this is an example of a patient that came to see me. You can see there on the left, the skeletal anatomy looks good, but I will say if you look at the front of the ankle and you look at the dorsal aspitalis, look at the soft tissue swelling and even posterior to the ankle, and that's one of the earliest changes that you can see. So in this patient, I got an MRI, and lo and behold, you saw edema not only in the talus, but you saw edema in the anterior and dorsal half of the calcaneus as well. Dr. Brand, as we talked about last week with foot ulcers, introduced the total contact cast. And again, we have an injury that results in edema, the classic signs of inflammation, warmth, redness, continued inflammation. You put on a total contact cast, what happens? It actually rapidly reduces the edema. It rapidly reduces inflammation and protects from further injury. So it's better than giving any medication to resolve inflammation. And it's amazing because if you put these casts on a patient acutely, in sometimes 3 or 4 days, the cast becomes loose because you have actually reduced the edema so much. So a total contact cast is the gold standard in somebody with an acute Charcot NeuroArthropathy. In 1966, Dr. Eichenholtz talked about the classic stages. Stage 1 was the acute localized inflammation where you have radiographic changes. Stage 2, the inflammation was starting to decrease and the bone was starting to heal. And then finally, stage 3 was the remodeling and the consolidation stage. And I would submit to you, wouldn't it be great if we could identify Charcot before we saw the radiographic changes, like I showed you in that particular talus in the previous slide. And lo and behold, Shibata in 1990 in Japan wrote an article about stage 0 Charcot. And he was actually dealing with patients with leprosy. And so he found in those patients with swelling, local warmth, clinical instability, but radiographic changes that were absent or minimum, he defined this as stage 0 Charcot. This is before the foot collapses and when ideally all of us can treat these patients. Now we know this as pre-Charcot or Charcot in situ. I prefer to call it stage 0 Charcot. In my opinion, Eichenholtz stages has 4 now, with stage 0 being this. Some people choose to make it even more simple and say that we have the active stage of Charcot or with the inactive stage of Charcot. But this is when we really want to make the diagnosis of Charcot, during this acute inflammatory stage before radiographic deterioration occurs. Dr. Sanders and Dr. Freiberg proposed their anatomic classification in 1991. And what we know that about 70% of Charcot patients in their series were involving the midfoot or the transverse tarsal joints. The forefoot and the hindfoot and ankle were much less common. Similarly, Jim Brodsky, around the same time, looked at his series. And again, he found that type 1 of the midfoot represented about 60% of Charcot. So we know that the midfoot is going to be affected in about 2/3 of patients. What about some treatment? It's only 22 years ago that we really started to see surgical treatment. And here's a case report using external fixation for the treatment of Charcot. It was a case report out of Iowa, and they used a unilateral frame for this. And a prominent textbook in 2000, only 20 years ago, said that external fixation should only be used in the presence of infection, large wounds, or gross instability. And then Dr. Pinzer in Chicago looked up his series and found that of his series, nearly half of them could be treated non-surgically with accommodative shoes after total contact casting, but about 52% required some form of surgery. And that surgery could be in the form of an osteotomy, ostectomy, fusions, incision of drainage, the ones that became infected, or even amputations. And then in 2000, Dr. Simon out of Ohio State at the time, really, I think, reported on a really pivotal study. Although it was only a small series of 14 patients, he operated during the acute phase, Eichenholtz stage 1. And this was really controversial because people said you shouldn't operate during this hypervascular response. And interestingly, when he did this, 14 out of his 14 patients had a solid fusion and actually did well. So he showed that infections were not necessarily higher in this group of patients, just simply because they had the inflammatory response. Anecdotally, I will tell you that in my own experience, when you operate on a patient and you realign their joint dislocation, as you see here, their inflammatory response dramatically reduces, especially because you immobilize them in a total contact cast. Now, the surgeries that one can do include an exostectomy. When you have a large ulcer like this lateral column, you can remove that plantar bone. And this is an article out of the New England Deaconess, where they really were one of the early pioneers in treatment of the diabetic foot, and another from Pittsburgh, where they also found that you could take off bone, and it actually works in a certain percentage of patient. It usually does not do any harm, although you have to be careful about removing too much bone because you can convert a stable deformity to an unstable deformity. And again, then Dr. Pinzer in 2004 looked at his own series for the midfoot, and what he found that in his midfoot cases, he could treat 60% of them non-surgically and 40% required some type of surgery. Now, the thing that I would say is inherently, I think, despite the fact that Dr. Pinzer is an outstanding educator, he's an outstanding surgeon, an incredibly honest person, there's some form of bias in this because of the patients non-surgically treated, they end up with a foot that's deformed. Yes, they can get into a shoe, but it is nothing near a normal foot. So are we accepting results that we wouldn't accept in other parts of the body? And so then Grant really talked about beaming for midfoot Charcot, and it really was a very stimulating thing. He's a mechanical engineer, And he started to think about inserting long screws up the columns of the bone to really resist these tensile forces, as you can see here. And he found that beaming was load sharing, and it would neutralize these tensile forces on the plantar foot, and it was a biomechanically sound form of fixation. And then about 2009, Dr. Samarco reported on his results, and then several others over the next several years, so that beaming has become much more common, as you can see illustrated in this particular photo. It actually is a really nice way to treat these. It's deceptively difficult to get these screws intramedullary, and it takes some experience, and you have to work with fluoroscopy to do so. So what I would ask is, if we're going to treat Charcot, what outcomes should we assess as we look at series? Because we really have to follow. We don't know the answers. Is surgery better than non-surgery? There's no randomized controlled study that tells you this. But I think we have to look on subjective outcomes of patients. We have to look at objective findings. We have to look at radiographic parameters, and we have to look at patient-reported quality of life. Are we making the patient's quality of life better with surgery than we would without surgery? The outcomes in Charcot, as I mentioned, are subjective, and the question simply is the patient satisfied or not? I would say in my own personal experience, most patients are satisfied, but that's my opinion. Does the patient have pain? Charcot patients often don't have pain, but some of the patients do have pain. And I think just like any part of orthopedics, we have to assess, is pain a problem? Objectively, can they wear non-custom shoes, or do they need some type of brace? And finally, is the foot unstable or is it stable? Is it plantigrade, as we're going to talk about? And so when we look at this, we see this foot's clearly not plantigrade, but how does one define plantigrade? It's very simple for me. It's walking on skin that was not meant to be walked on. For instance, in this case, if you're walking on the lateral border of the foot on the arch, that arch skin was never designed to be walked on. The side of your foot or over the lateral malleolus was not meant to be walked on. So I look at a plantigrade foot as one as you're walking on the skin that was meant to be walked on. And so is the foot ulcer free or infection free? So to me, those are important outcomes. Did you restore the alignment so that the foot is plantigrade, and have you relieved infection or prevented infection from occurring? Those are very important. So here's an example of a patient that had a rocker bottom foot. As you can see, it was a very healthy, clean ulcer present, and we reconstructed that person, and simply by reconstructing them and getting the bony prominence removed, their foot became healed. And I think you can look at this, and this patient has other signs of neuropathy, as you can see, the hammer toe deformities, autonomic neuropathy of skin changes with dry skin. So clearly this patient is a high-risk patient. And on the left, you see that ulcer. Eventually this ulcer would be infected and could lead to devastating consequences. Radiographic parameters. We look at Meary's angle and calcaneal inclination angle. And you can see in this particular case how the talus is plantar flexed. And so if you look at Meary's angle, that's very abnormal. That angle should be 0 or 180 degrees if you look at it. If you look at the calcaneal inclination angle, it's actually reduced as well. So there's an equinus component to this particular patient. And this is a post-op on this same patient. And you can see that we restored Meary's angle, and we've restored and improved the arch. The arch is not absolutely normal, but it's better than before. I think cuboid height is something that I look at very critically, because I know that a negative cuboid height is a predictive of ulceration. And so when I see bone below the weight-bearing line, as you can see here, I know that over time, this is going to break down and lead to a foot ulcer, and that foot ulcer could lead to infection. So I'm very aggressive when I see a negative cuboid height. And again, this is an example of that particular patient. Whoops, I'm sorry. That our negative cuboid height, you can see we've restored that. And so now we don't have any bone below the weight-bearing surface. And hopefully with time, that will not result in any ulceration. Again, those are my opinions, looking on my own personal series. Ultimately, we hope to show that this is true through studies. We look at the Meares angle on the AP, and you can see the abduction deformity of the foot here. And clearly, the talus and the first metatarsal are not collinear. After surgery, you can see in this patient, the talus and the first metatarsal are in fact collinear. You can see on the left, that would be difficult to put in a non-custom shoe. The foot on the right should be able to be worn in an accommodative shoe. It does not necessarily have to be custom. It could be off the shelf with some inserts. We know that diabetic foot disease reduces health-related quality of life. As you can see on the bottom here, there are multiple studies, to include some from our own institution, that show that Charcot foot is associated with reduced quality of life. So as we tackle this problem, whether it's surgical or not surgical, we should have in mind the goal to improve patient quality of life. That's really a key. We also know that Charcot disease is a surrogate marker of other medical complications. You can see the 5-year survival here of a Charcot foot is a little bit over 50%. People say that amputations are bad. Well, it's not that much different than a Charcot foot or even a healed diabetic foot ulcer. Why do these patients die? Because they have comorbidities of peripheral artery disease, which can cause stroke. They have coronary artery disease, which can cause a heart attack. They have renal disease, which can cause kidney failure. So the Charcot pathogenesis, as we review it again, neuropathy, that's ubiquitous. There is some form of injury, whether it's perceived or not. It most commonly will occur in males, most commonly in patients with type 2 diabetes. And the question is there some other factor that makes these particular patients more vulnerable than the other? And I think that this is where we're going in the future. What about genetics and DNA and what we call polymorphism? So if you look at this study by Patoko, they looked at polymorphism of the osteoprotegerin gene. As I talked to you before, osteoclastogenesis is really based on a balance between rank L and OPG. OPG is a decoy receptor for rank L. So if rank L is blocked by OPG, you're not going to resorb as much bone because the osteoclast won't be activated to the same degree. So they looked at Charcot patients, and again, defective OPG, if you have this polymorphism, means there's less OPT to bind to rank L, so rank L will be more unimpeded. And what happens is they stimulate osteoclastogenesis, and you get an imbalance now where rank L becomes dominating over osteoprogenesis, and then these osteoclasts get activated and they start to activate bone. So this is an interesting concept. Maybe down in the road that we see these high-risk patients with neuropathy, that we can do a blood test someday and say, okay, they've got a polymorphism for OPG, and we need to really protect those and identify these patients. And this is not just in that particular study. This was a study out of Poland, another study out of Czechoslovakia, and finally a study out of India, where they're all looking at the polymorphism in these various genes in patients for Charcot. So the future, I think, what about anti-inflammatory medications? We know that we use them for rheumatoid arthritis, and they're TNF-alpha inhibitors. They're very, very great against inflammation. They're useful in things like rheumatoid arthritis, Crohn's, ulcerative colitis, psoriasis. Is that a possibility that we have this acute inflammatory problem? Can we treat it with a TNF-alpha inhibitor? What about human monoclonal antibodies? That's a possibility. The rank L inhibitor, that's actually used in something like cancer treatment. What about genetic manipulation? If we identify these patients with polymorphisms, number one, can we identify and identify them before they develop a Charcot and protect them? Or can we manipulate their genes that are being done now by implanting different genes? So if you are thinking about surgery in a Charcot patient, I always say keep in mind about perfusion. Critical limb ischemia is rare in Charcot. It's more common in patients with diabetic foot ulcers, but it can occur in a small group of patients. And you need to have toe pressure above 55 to get healing. So I would say that we actually will do non-invasive studies on all of our patients, because remember that toe pressure above 55, your ABI may be unreliable in these patients because they have calcification of their arteries, because diabetic patients do. So we always check the toe pressures. And here's a curve that looked at healing of diabetic foot ulcers. And you can see that the toe pressure in red, the magic number for healing is about 55. The magic number for an ankle pressure is almost 100. And the bottom line is this sigmoid curve is very consistent, but you want to make sure that you're going to have potential for healing. And remember that patients with diabetes have infrapopliteal disease, where the tibioperoneal trunk's involved. There are three major arteries we have to worry about: the posterior tibial, the anterior tibial, and the peroneal. And what's really important if you're going to do a Charcot reconstruction on the foot and ankle is to make sure that you have an arch that's reconstituted. As you can see here, you can see all three arteries come down, and there's perfusion through the arch. It's rare to have ischemia in Charcot patients, but it does occur, and just make sure that you don't deal that. You don't want to find that they have significant peripheral artery disease after you make your incision and it doesn't heal. So the key summary points for Charcot: high suspicion in those neuropathic patients. Make an early diagnosis. Once we make the early diagnosis, let's prevent the deformity. If we prevent the deformity, we prevent ulcers and infection. And if we prevent infection, we prevent amputation. The vast majority of infections in patients with diabetes occur in patients who have a wound, and 85% of amputations in diabetes patients occur in patients who have a wound. So it makes sense that if we can prevent a wound, we can prevent an infection, and we can prevent an amputation. And I want you to remember that Charcot is more common than we think. Patients present because they have neuropathy. They may not present because of that. We may not see them. They may heal on their own. So it's more common than we think. And I like to quote this gentleman from Ireland, Dr. Lindsay, who actually said, for one mistake made for not knowing about a subject, 10 mistakes are made for not looking. We have to look for Charcot. We need to change our mindset. Charcot is really a neuropathic fracture dislocation, and we have to think of it like that. Currently we think of Charcot, it's a non-surgical problem. We're going to treat this non-surgically because there are so many complications with Charcot. Let's call it what it truly is. It's a neuropathic fracture dislocation. Where else in the body would we treat a fracture dislocation without surgery? If we have 2 millimeters of displacement of a distal radius, we fix it. In a patient with an ankle fracture, we fix it. Why not bring Charcot treatment into the 21st century? In 1977, femur and tibia fractures were treated with cast. You can see this classic article, cast brace, for femoral shaft fractures. Nowadays, tibia fractures and femur fractures are treated with intramedullary nailing in the most cases. Yes, you can treat them with cast, but this allows people to get up and move about. And I would say to you that, compared to 50 years ago when we treated Charcot without surgery, we have better internal fixation techniques. We have better external fixation techniques. We know a lot more. We can manage glucose better. So the point is, I think we have to really change our mindset and really call it a Charcot neuropathic fracture dislocation and treat it like every other fracture dislocation or displaced fracture in the body. And I always like to say that you may not have seen Charcot, but Charcot has seen you. Be a medical detective. Don't miss a diagnosis or misdiagnose a Charcot patient, as you can see here. Again, on your left, you can see early signs of soft tissue swelling, and this patient wasn't recognized and ended up having an injury to the talonavicular joint, the ultimate Charcot. So I want to thank you for this. Again, I'll take any specific questions. I recognize that this didn't talk about specific forms of fixation because that in and of itself is a whole talk. And if Professor Gopalan wants me to, I'd be happy to talk about ankle Charcot once and midfoot Charcot and the surgical management. Thank you very much.
Thank you very much, Professor. Excellent presentation as usual. Of course, we always would love to have more presentations because it's always lovely listening to you. A few questions.
Yes.
Prof, regarding the modified Eichenholtz classification, Now, does this classification allow you to guide treatment purposes? For example, stage 0 or pre-fragmentation, we talk about orthotics, and when do you do the beaming screws, or when is it possible to do a distraction external fixation?
That's a great question. I think the Eichenholtz class, traditionally, when we would intervene in surgery with Eichenholtz, we would always wait till the stage 3 when it was consolidated. And at that point, surgery is actually hard and complicated. You have to do osteotomies, arthrodesis. I think to me, and again, I'm speaking now as somebody that has a special interest, and I recognize that my views may not be mainstream. But as I mentioned to you at the end, I like to think of this as a fracture dislocation. If I see a Charcot stage 0, get an MRI, I will immobilize that patient until I see resolution of the acute inflammatory stages. If I see any subtle displacement of the midfoot for sure, I will treat that like I would a Lisfranc injury in any one of us or any young person. I believe that that's the best time and easiest time to treat them. I realize that that's my opinion. I haven't proven that, but I believe that by intervening acutely before the bone has dissolved, that you can actually get a very, very excellent reduction. I would always incorporate an arthrodesis in a Charcot patient because I can get good stable fixation. But to me, when I do that, I feel very good that the alignment is corrected. I get a solid arthrodesis, and I'm going to prevent them from developing a deformity and an ulcer. So my goal, and the way I think of this, is by intervening early, I'm going to prevent a wound from occurring, infection, and ulceration and amputation. I can also tell you in my own personal experience of hundreds of cases, I can only recall one patient in several hundred that's ended up with an amputation after I operated for an acute Charcot who didn't have an ulcer. So that means that 99% everybody's worried about infection and amputations, but it really doesn't happen very much in patients who don't have a wound. Once you have a wound, totally different problem. And again, that's another subject we could talk about, but increasing a wound once you get a wound with a Charcot, it increases the risk of amputation by a factor of 12 in that one study. So to me, the goal, whether you treat them surgically or non-surgically, is to prevent a wound. For me, and again, as an orthopedic surgeon, I view this as an orthopedic surgeon, and I would ask any orthopedic surgeon, if you had a displaced tibial plateau of 2 to 3 millimeters, you would fix it. You would have a femoral neck fracture, you would fix it. If you had a ankle fracture, you would fix it. Or distal radius, you would fix it. A Lisfranc injury in an otherwise healthy person, we would all fix it. Yet we let these patients who can't feel the bottom of their feet fall apart and develop severe deformity. Again, I recognize, I want everybody to understand this is my opinion. It's somewhat radical, but I think, again, if you're treating a patient that comes in with a tibia fracture or a femur fracture today, how many people get treated like that in a cast brace? Not too many. Most people will get an intramedullary nail. Hope that answers your question.
Yes, Prof. Do you have an experience with external fixation, distraction?
I have a lot of experience with external fixation. I think that if you had a displaced Charcot acutely and you got it very early, you could put on an external fixator and do gradual realignment correction. You know, there are computerized programs. Several different companies have them now that you can do that. The other thing you can do if you do it really early is you can put an X-fix on, and then before you tighten everything, you can use the external fixate and distract it and reduce the joint with like a joystick and then get them lined up. So external fixation in people that are comfortable with it are also very valuable as well. But I will say that external fixation is not without its complications. I actually wrote an article about the complications of external fixation, and I found that if you leave them on long enough, 100% of patients will develop a problem. That could be a broken pin, a pin tract infection, and I've even had patients who've actually tibia fracture after you removed through a pinhole. So external fixation is not without complications, but I think for a truly a person who's a reconstructive Charcot surgeon, you should be facile in internal fixation, you should facile in external fixation, and you should be facile in using hybrid techniques, both of them together.
Thank you very much, Prof. Prof. Senthil is also online. Senthil, can you
Yes, sir.
unmute?
Yeah.
Questions to
Dr.
Prof.
Wukich, as usual, very wonderful presentation. So this is a very difficult problem. Being a foot and ankle surgeon, you'll mostly see the patients after they developed a deformity, with or without ulcer. So when they have an ulcer and your MRI shows, or if there is already a deformity, would you still use the beaming, or is there a role for bone biopsy to rule out an infection?
I think the way that I would approach it, Senthil, is if I see a patient with Charcot with a deformity and an ulcer, the question is the ulcer infected? It's always colonized. If you have an ulcer that's not infected, I would use internal fixation. I've done that. Again, that's my opinion. I think that there are some studies that would support that. But it certainly would be prudent if you wanted to do a percutaneous bone biopsy. That's a very good thing to do. Some people, and I think that this is wisdom on their parts, they have an ulcer. What they'll do is they'll mobilize the patient, get the ulcer healed, and then do reconstructive surgery. Very, very reasonable thing to do. My experience has been that you can oftentimes get a patient to heal with a deformity by total contact casting, but they always recur because of the deformity. And so my bias is when I see a deformity in an ulcer, I know that the recurrence of that is going to be so high that I will recommend surgery. And I didn't put the slide in here, but my algorithm is if it's grossly infected, I use an X-fix, no question about it. If it's not grossly infected, I will use beaming. Now, in some cases, I'll actually use a hybrid technique. I think, again, that depends on your experience and how comfortable you are. And I think that, and with every technique, but I think it's, my experience, I've had good results of using internal fixation in patients with a wound who don't have an infection. Now, one of the things you certainly if there's any osteomyelitis, I would not put internal fixation. I'm sure that if you would culture every wound that you do, they have antibiotics. And quite honestly, my approach is I actually in the operating room, if my clinical suspicion is that it's not infected, and they also have normal indices, CRP, I will debride the ulcer before I start surgery, re-prep and re-drape, and then I will actually do some deep cultures, put in my internal fixation. If those deep infections would come back, then I will treat the patient with long-term antibiotics, much like you would in a periprosthetic joint infection that you found, I would use oral and suppress them. So I've actually had that work pretty well. Again, those are my opinions. And if I were a young person taking my boards in a board collection stage, I wouldn't do what I do.
Okay. And the other thing is, most of the time you see patients have either because they developed a deformity or their ulcer is not healing. So do you think, what would be your advice to the primary care providers about identifying this patient at an early stage and refer to a foot and ankle surgeon?
I think that's absolutely the number one thing. If I could, I would love to be on the speakers bureau for every primary care conference in the United States and talk about this and let them. I've actually given the same talk to the emergency departments, and usually after I do that to the emergency department, they get scared because they see what can happen, and then the referrals happen. Like anything else, they start referring a lot, and then 6 months later, forget about it. But I think educating patients, educating primary care physicians, advanced practice providers, quite honestly, that's where we could make a difference. Because I know that if I could see these patients early on when that stage 0 is occurring, or even early stage 1, it's in my heart that I believe that we would reduce the rate of amputations tremendously. So I would like to see more of these patients. And if they turn out that they don't have Charcot, that's okay. I think all of us that trained as surgeons many years ago, we did appendectomies. And I remember when I was a general surgeon in 1982, they told me that if you didn't take out normal appendix once in a while, you were missing appendicitis. So, and nowadays they do ultrasounds, but back then, people had right lower quadrant pain, you operate on them. Same thing with this. I think it's okay to overtreat these patients. If a patient comes in and we offload them and it turns out that they don't have a Charcot, but if their MRI shows edema, they have pre-Charcot, they're going to develop Charcot. So I think, around the world, not everybody has the luxury that I have. Some places, I I have colleagues in Africa, they don't have an MRI, they don't have a bone scan, they don't have a CT scan, but they do remarkable things treating patients with very limited resources. But all we need to treat a Charcot patient is immobilization, offloading. If you have a patient high risk, hot swollen foot, offloading, immobilize that patient. Those are pretty simple things, but we just have to educate people. Even to this day, I'm always amazed at how many patients have a misdiagnosis. And if they get in, as an example, oftentimes if they go to the emergency room, they get admitted to internal medicine and they get diagnosed as cellulitis, or gout or DVT. They put them in the hospital, put them on antibiotics, and guess what? They get better. And the reason they got better is they've been laying in a hospital bed offloaded. Then they go home and they say, okay, your x-rays are normal. And then they walk on it and it falls apart. So I think that's the time to see them.
Thank you, Dr. Wukich.
Sound like
Okay, thank you very much, Professor. I think there are no more questions. Thank you for your fantastic lecture and you sparing your valuable time with us. Of course, we really look forward for the other lectures that you mentioned. We're always ready to host you.
I'd be happy to talk about management of ankle one day and management of midfoot, because that's a whole host of topics, and I could spend, like I said, as you can see, I'm passionate about this. So
thank you very much, Professor.
Take care. Thank you
very much.
Thank you, Dr. Wukich.
Bye-bye.
Thank you, Stage. Bye-bye.
Take care.